Good afternoon. Thank you very much. Welcome to this session, Physiologic Guidance and Optimization in Multivessel Disease, sponsored by Philips. My name is Nieves Gonzalo, and I have the pleasure to be in the session with Rachel Lamey, who will be the spokesperson. As discussants, we will have Matthias Gottberg, Eric van Wel, and Javier Scanet. So let's start with the objectives of the session. And you can see them there. The first objective is to learn how physiology pullbacks and angiographic co-registration can help to define the patterns of atherosclerotic disease and guide treatment strategy. Second objective would be to understand how to optimize PCI using physiology. And finally, also to learn key tips and tricks to obtain accurate physiological measurements. It's very important also your interaction for this session. So please, if you have any question or comment, it is welcome through the microphones and also through the app. Dr. Lamey will be taking care of your questions. So please interact. This session is made for you and for your questions. So we can start with Javier, who is going to present us a case. Thank you very much.
Well, thank you. Thank you very much, Nieves. And again, it's a pleasure to be here with you. And what we are going to do is to share with you one of the cases that we perform in our everyday practice. I must say that is the type of way that we perform our studies in our cath lab. These are my conflicts of interest. Let's start by seeing the characteristics of the patient. 70 years old gentleman. He presented with syncope, but during the workout, it was found that he had a previous history of ischemic heart disease with an anterolateral STEMI 6 years before, and a primary PCI to proximal and mid-LAD. Of course, the fact that this gentleman had atherosclerosis and had this event probably was related to the cardiovascular risk factors. He was a smoker, hypertension, and dyslipidemia. These were his cardiovascular risk factors. Now, the left ventricular ejection fraction was moderately depressed, 35–40%. There was an akinesia of septum, apex, and arterial wall that, of course, casted some doubts as to the viability of these segments, myocardial segments. And this is the anatomy. I think that you can immediately see extensive coronary artery disease, lots of calcification, as you can see here in the angiogram, stenosis in the left main and also in the circumflex and LAD. You can see better here the stent that was previously implanted. You can see it here. And stenosis probably distal to that. And in the next one, this is the right coronary artery that had no significant stenosis. So there was the patient was discussed. The consensus is that it should be considered performing revascularization in this patient who had depressed left ventricular ejection fraction, and we performed the anatomical syntax score. Of course, the syntax score too that gave us an impression on what would be the 4-year mortality for both PCI and CABG, and it also provides automatically a recommendation based on statistics on whether PCI or CABG is indicated, and there was an equipoise of risk. The patient was considered a low bleeding risk patient. In summary, patient with long-standing coronary artery disease, prior anterolateral myocardial infarction, drug-eluting stent implanted in the proximal mid-LAD, most likely non-viable myocardium in part of the LAD territory, extensive vessel calcification and stenosis. You can see them here in the left main, mid-LAD, and circumflex. So based on this, we thought that this would be the sort of sequence that we should carry out. Nieves, should we stop? Let me know if at any stage we stop and make discussions on this. We considered performing physiological interrogation of the left main stenosis and LAD. We were wondering, if both of them were significant, if only one of them was significant or not. We also thought that, after that, depending on the results, we would be interrogating the vessel with IBUS. And if we decided to go ahead and perform intervention, it was most likely plaque preparation will be needed based on the calcification that we saw in the angiogram. But of course, we will be guided by IVUS findings. And of course, the optimization of the intervention will be based on IVUS and physiology. So I will continue then, and I will let you know the first steps. So here we are in the cath lab with Nieves, like we do in many occasions. Here, just to refresh the anatomy now with more clarity, you can see this stenosis. And we perform first this longitudinal analysis, this single spot measurement, which reveals that certainly you have flow-limiting disease in this vessel. But now we perform this longitudinal vessel analysis that very clearly demonstrates a sort of tandem pattern. You can see that this is obtained with what is called the IFR Scout tool, that is a dedicated software for pullback analysis with IFR, and subsequently this information is co-registered with the angiogram to have a much more sophisticated tool. Now, there's lots of interest in longitudinal vessel analysis, but the beauty about angiography co-registration is that allows you to predict what are the results if you perform a particular intervention. So in this case, for example, if you treat this stenosis, the result will be suboptimal. And you can see clearly that only if you treat the mid-LAD and the left main, you will achieve an adequate result. So something that I would like to emphasize is not only having the longitudinal pattern of disease, is having the expertise and the tools to make predictions on what are going to be the functional results of the intervention when you have the patient in front of you. And I'm sure that in the future, this will be a prerequisite. Before embarking into treating a patient, particularly someone who has, this degree of calcification, this degree of complexity, you really have to have some rational ground to say, if I treat this, I will get a good result. This is, I think, that's something that's important. So based on this, we were happy about this, but of course, there was a question about the left circumflex. So we repeated the same operation in the left circumflex. Again, we see that there is flow-limiting disease, an abnormal IFR, as you can see, distal to the coronary artery. But now let's see what happens if we remove the effect of the. What is telling us is that distal to the left main we have an IFR of 0.91. This is interesting. If we remove the effect of the left main, we can clearly see that the stenosis in the circumflex by itself is not ischemia generating. This is something important. So we have obtained a very nice information now. We know that in the left main LAD we have to treat both stenosis if we want to achieve a good result. But now we know that we don't have to bother about treating the stenosis in the mid-segment of the circumflex. The effect that we are seeing here, the abnormal IFR, is due to the stenosis upstream located into the left main. So, Nieves, I will stop there probably.
Yeah, maybe it's a good moment to stop and to enhance the interaction with you. We have decided to propose you a poll with a question about how would you treat these patients. So if we can show the poll, please.
So I think just while they're getting the poll ready, just to ask you, one of the audience members has asked us, what are your tips and tricks when performing IFR? Are there some particular tips and tricks that you'd like to share with the audience, Javier?
Yes, I think it's a very good point. I think that the first thing you have to do when you are performing IFR is making sure that the catheter is free of contrast. And you really have to have a beautiful superposition of the waveforms obtained from the pressure guide wire and the catheter before you moved into the vessel, because IFR in a way is like microscoping into the gradient over the cardiac cycle, and therefore if you have any misalignments of these two curves, you may have some false positives. So this is the first thing I will say. The second thing is that once that you advance your wire, make sure that you have flushed again the catheter and that you wait a bit until the effect of the saline disappears, because it induces a part of hyperemia. And finally, if in a case that is complex and you don't feel happy like bringing back the guide wire, the pressure guide wire back to the origin, just place another conventional workhorse wire in the vessel, and then you use the pressure guide wire to interrogate. You always will have access to perform interventions with the second guide wire. There's virtually no interference of a second guide wire.
Thank you, Javier. So now I think we're ready with the poll. So if we could just display the poll for the audience. Yeah, so hopefully you can see on your apps. So the question is, based on these findings, how would you treat the patient? Would you treat the mid-LAD, the LAD left main, and circumflex lesions, so all of those lesions? Would you just treat the mid-LAD and ostial LAD and left main lesion? Or would you only treat that ostial LAD into the left main? Brilliant, so we have some results, and I think there's still some people voting, but they tell us they treat the mid-LAD and the ostial LAD left main lesion. Maybe it's a good time to ask the panel. So, Matthias, Eric, do you have any thoughts? What would you have answered in the poll?
I don't know, but I have a question for Javier. How do you integrate the non-viability of the LAD in the picture?
Well, by definition, if there is flow down the vessel, if you have flow, it implies that there is viable myocardium. This is something that is important. And particularly if you have a gradient. I mean, if you have a gradient, every time that you see a pressure gradient, when you put a pressure guide wire across a stenosis, it implies two things. First is that there is some degree of flow limitation. And the second one is that there is a microcirculation that is trying to accommodate the effect of this flow limitation. This is something very, very important. So in this particular case, we believe that the information that is telling us is saying, well, perhaps, not all the myocardium is viable, but the severity of the stenosis we have there is flow limiting for that amount of myocardium that remains viable. This is the way they interpret it.
Matthias, maybe you can answer. What do you think about the poll findings? Would you have answered with the majority?
I would. So I think that in terms of this, we see that mid-LAD is obviously a tight lesion that is something that we want to treat in order to make the patient non-ischemic. And also the LAD left main we need to treat. The main question is really, do we need to do a two-stent technique, or should we go provisional? And I think that if I saw one of the caudal views, I think it looks like the circumflex looks pretty good. So I think that the contribution is really in this part of the left main. So I'd probably go for a provisional in this case, unless I think it's a high risk of having a plaque protrusion in the circumflex.
So I think the case reflects very well how the use of physiology has changed from really focal distal measurements that in this case probably wouldn't tell us much about it because there are multiple lesions. There is a stent, there is a patient that has previous infarction there, to go to a longitudinal vessel examination that is providing so much information about the importance of each lesion. I have a question for you, Javier, about the use of physiology in left main. Some people have concerns about if this is validated enough for the left main, if this can be used in left main. Any tips, also tricks when you are examining the left main? In this case, it's a distal left main, but for example, in case you have more diffuse disease or more proximal left main lesion.
So all the studies that have been looking into the decision making with pressure guide wires in the left main, irrespective of it is FFR or IFR, they have used the same type of study design. That is, you have patients that have an IFR, FFR positive, you treat them, and you compare the outcome with those that have a non-significant FFR, IFR, and that were left outside. This is a design that has been used everything. There's no been any study making randomization, to perform, not perform interventions. And all these studies have demonstrated for both of them that both techniques are equally safe, and that it is safe to differ based on pressure guide wire. Now, today, just a few minutes ago, there was a late-breaking clinical trial presented by Takayuki Warisawa that was adding something else to this. And what he found is that, yes, okay, it's perfectly all right to differ. Now, what happens in those cases where you have a discrepancy between FFR and IFR? And what he found is that in those cases where you have an FFR that is patients that are differ, those cases where you have an IFR that is negative against an FFR that is positive, it is better that you follow IFR. This is basically. So, in a way, the message, the best way to discriminate, according to the evidence we have on this trial that has been just presented today, the best way to discriminate if a stenosis is in the left main is non-significant is IFR. This will be the take-home message. But overall, you can safely rely on the use of physiology to know if there is a flow-limiting stenosis in the left main.
So maybe we have one more question.
Yeah,
maybe have one more time for a question from the audience. So the next question, and maybe I can ask you, Nieves, maybe to help us with this. So the question is, how do you, in terms of serial lesions, you've obviously talked about the importance of the pullback, but are you happy that you can discriminate a left main lesion from a circumflex lesion, left main from LAD? Is there any issues of the presence of serial lesions with IFR?
Yeah, well, I can say a few words, so maybe you can answer more in detail, Javier. I think that actually with IFR, this is possible, and this is actually what is demonstrated with all these studies with longitudinal examination of the vessel, and especially in the situation of co-registration and the prediction actually of the result of stenting with different strategies. And actually, the interaction between lesions and the crosstalk between lesions that can be a problem. This problem is less important when you're using resting indices. So maybe you can elaborate a little bit more, Javier.
Yes, it is. This is the evidence that we have so far. The crosstalk between the two stenosis, because the problem you may have typically with FFR is that if the distal stenosis is severe, you will always get fooled about the proximal one. Once that you resolve the distal one and there is full flow, now the proximal one becomes significant when at baseline it was not significant. Now, this crosstalk also happens with IFR, but in order to have that, you really have to have a very, very tight stenosis. So whenever you have a stenosis that is limiting flow at rest, then you may have that. So my suggestion is whenever you put your pressure with a tandem stenosis array like this one, and you find an IFR of 0.60, of 0.50, reassess after you have treated the more severe one, because it may happen, that there is some crosstalk. But I think that that's part of the game.
So one of them is very tight. So maybe we can continue if
we've got more questions, but we can bring them up as we go through.
we can continue and then take more of these questions after the next part of the case.
Okay, so the first thing, of course, that comes next, and we have to emphasize a lot that imaging and physiology are synergic. They are giving entirely different and important answers to questions made to the operator, is understand what happens there. And immediately, in this particular case, you could notice that we were not able to cross the IBUS because this was this ring of calcium in the left main. So we pre-dilated the lesion with the balloon, and then we reinterrogated again the vessel. This time it was possible to negotiate to cross with the IBUS catheter. Something that is interesting of this IBUS catheter is that you have markers also that are very helpful sometimes in estimating the length of the stent that you need subsequently. But now let's focus on what we see here. We saw the stent. The stent actually has a very good result in the long term, as you can see. There is no restenosis. But let's focus in the most proximal stenosis, which is in the left main, which is probably going to be the tricky one. And here we start seeing, a ring of calcium. You could see a ring of calcium. Probably it's a large plaque in the vessel here. And soon we will see. I think that we are reaching now. This is one of the aspects where everything becomes much clearer when you perform co-registration. So now you had to make a mental operation of saying this image that I'm getting, which vessel corresponds to. But now with co-registration, it is very easy really to understand the presence of disease at specific points in the vessel. And this is important because you are going to be using the angiogram later to guide further actions like. So you could see that there was a disease certainly in this region here, proximal to the diagonal. This is the stent, which we saw before that actually has a very good long-term result. No, but then we move to the proximal part, and then is when we see this ring of calcium that is in the proximal LAD and left main. Here you have a more mixed plaque, then a very large vessel. What comes next, of course, is to make some measurements to understand the stenting strategy. This is something that you can do very easily. For example, here we can see that the vessel is around 4.7 millimeters. That means that we have to use a stent that probably, if you overlap it with the stent that has been implanted, it can be expanded from 3.5 millimeter to 4.5 millimeter. You really have to look to the ability of expansion of the stent that you are considering. Then, of course, we have, this is when you are choosing a stent like that, then you are ensuring that you don't have negative remodeling, and that therefore the implantation of the stent might lead to perforation of the vessel. It's not the case, of course. It's a very large vessel, as you can see here. And based on this information is when you will select the landing zone. In this case, it's very simple, I believe, because we have this stent previously implanted, and then you have the proximal one. So this is the, sorry about that. So the first thing we did is performing some plaque preparation. We are not seeing it here. We used in the proximal part lithotripsy, IBL. And for the sake of time, we have skipped this. We are now, after performing plaque preparation, I believe that this is the stent deployment, probably at the time that we are doing here. We are overlapping with the previous stent. This is POT, performing POT after the stent implantation. You can see the huge amount of calcium that is there. And based on this, we move to assessing the results with physiology and with IBUS. So with IBUS, we of course focus in the area of overlapping the two stents, and then ensuring that we had achieved a good result in the left main and proximal LAD. As I say, we skipped for you all the plaque preparation with IBL, etc. We have nicely matched the stent to the left main, as you could see there. And we always perform co-registration whenever possible, because this, of course, makes our life much easier in terms of assessing specific locations inside the vessel. And we were very satisfied with these measurements. These are some of the measurements that we have there. So then we move to physiology. We have now positioned the wire distal. We are performing back a pullback. And and this is interesting. In this particular case, we found that we have down here, we have residual disease. So despite that we performed this type of initial assessment, we now found that there is some residual disease that should be treated. And that's the reason why it is important to perform this type of assessment. So we did that. We protected the side branch, as you can see there. This is the treatment. We're performing some rotational angiography to make sure that the balloons are properly expanded in different angulations, that there is no eccentric expansion. And now we performed a new pullback, which we'll see in a second when we co-register with angiography. So now there was a question before from one of the colleagues about tips and tricks. I think that we are going to show you a very interesting tip and trick here in a second. Trying to refresh my memory now. This is some of the. So this is the measurement that we obtained. That you may think at the beginning that is not that good. Let's have a look to it. But look at this, because it's very important. The value of IFR is not reaching 1 at the point of the guiding catheter. This is important. So for whatever reason, there was a small drift in the value, and we will see this in a second. So the first thing we did is, in any case, we co-registered. And when you co-register this, you can see that there is no longer focal flow limiting disease. You have a evenly distributed loss of IFR values caused by friction, but there is no focal stenosis that there is room for treatment. And in addition to that, when you look to the characteristics of the curve and you correct, and this is something that you can do, easily look into it. If you adjust for the pressure drift, you actually find that the result is more than good. So this is probably what it will be the best possible result you can achieve. You are generating for large segment of the vessels, values that are above 0.90. And if we go back to this, it's clear that there is nothing we can solve here. I mean, treating this with very aggressively probably will be associated to more risk than benefits.
Maybe we stop you there, Javier, just to also go to the poll again. Just in terms of what the audience might do with this final IFR result and what they think we should do in terms of doing anything further. If we get the poll ready. So just in terms of the Q&A, there's a few more questions. We've had a question, do you worry about post-PCI IFR as opposed to pre-PCI IFR? Is there any difference? And what data do we expect to be coming out in terms of guiding us from the point of view of IFR?
So the rule that we have, that we recommend nowadays regarding final IFR and final FFR, and all this is work in progress because you know that there is lots of interest, is that whenever you finalize with an IFR, you have obtained a very good result, and you find an IFR that is abnormal, and particularly when you see that it is abnormal because you have focal stenosis or whatever, you may consider using FFR. The reason for it is because the patient at the end of the procedure may not be the same patient that at the beginning. What I mean is that someone that has been, subject of long balloon inflations that have generated reactive hyperemia, someone who is nervous because perhaps has felt some angina symptoms during the procedure, etc., this patient may no longer be in a resting state. There is some work from Korea that demonstrates that whenever you have a negative, normal IFR at the end of the procedure, you are perfectly safe. And it is the benefit of optimization comes from those patients where having an abnormal IFR at the end, when you check with FFR, you find that there is also abnormality, and then you continue further. But in this particular case, it's an entirely different thing because you can see this diffuse pattern of pressure loss where, insisting in improving that will take you nowhere.
Thank you very much, Javier. And maybe I'll come to the panel again. Eric, are you happy you would just accept this result with the diffuse pattern of disease?
Yes, I would be happy, but I have a question for Javier. In that case, you plan your PCI based on the pre-IFR pullback using the co-registration. You followed the plan, and still you were measuring at IFR at the end. Do we need to do... So, because you could say, okay, my plan is I expect an IFR to be 0.89. I have put the stent where I should put them. I have checked with IVUS, everything is okay. Is it possible to stop that there, or should we still do an IFR at the end?
Well, I mean, we typically, having the wire on the table, we feel reassured when we put the pressure wire at the end and we see that, we have achieved a good hemodynamic result. And if we find an abnormal result, then we give some thought to it. And that's the reason because I was insisting that in this case, the correlation with angiography and the demonstration that there is not a focal residual stenosis that you are leaving behind is very reassuring. That's what I will do. But, the important topic for the colleagues is that, in a way, post-PCI physiology is more challenging than pre-PCI physiology, I believe. That's my personal impression. And that applies also to FFR. If you look to the target FFR trial, for example, in the target FFR trial, they struggle to get what they define as an optimal result with an FFR of 0.90, and actually the study could not demonstrate that this was achievable. So even if you strive to do that, so that's why, you know, it's at the end of the day it comes also the common sense and saying, well, overall the objectives of the intervention have been fulfilled. We predicted that we could, you know, improve the hemodynamics of the vessels, and we did. But it's true that, you know, common sense will probably say, do not go any further, because chances of improving these are small, and probably you will also have more chances of having a problem.
Thank you, Javier. Maybe, Matthias, if I could ask you a question from the audience as well. With diffuse disease, do you ever consider bypass with the LEMA to the LAD? Do we have any evidence that that's more preferable in these patients?
Well, I think this is actually one of the best ways of using IFR as well, that we can integrate all the information, not just having a solid cutoff point. And just by using sync vision means that we can distinguish between focal disease and diffuse disease and the mix of there in between. And I think that, you know, there's no really easy for us to achieve a good end results if you have total diffuse disease. Yes, we do PCI on them occasionally, but that means basically full metal jacket, especially in the LADs. So I think we kind of shy away from doing that. And we know this from, among other syntax trials as well, that any patient that has long diffuse disease in LAD are going to have high syntax score as well. I just want to comment also on the post-PCI physiology part of it, is that I'm part of the defined GPS trial, and we look at all the defined GPS cases after and they've been included, and we find a lot of stent under expansion in those cases where you actually think you have a good results, but if you do imaging that is actually mandated, if you have a pressure drop inside the stent, quite often you see stent under expansion. Or, as the Javier pointed out, is that sometimes if the patient have had chest pain, been lying there for a while, they're not really in a resting state anymore, so it might actually not be a resting flow. But I would have a very low threshold for doing post-PCI physiology, but also doing post-PCI imaging to check my result afterwards.
Yeah, and actually that's very interesting, no? Because we maybe one important message for the colleagues here is, what is the optimal cutoff value? I mean, no, because we always like to have cutoff value, so I have to have an FFR over 0.90 or IFR of 0.95, I think was coming from the original defined PCI, that's the optimal. And sometimes this is just impossible because you have this diffuse disease in some parts of the vessel, and there is a region that you can treat, but there is some diffuse disease left. So really don't get obsessed with numbers, just be sensible and try to achieve what you planned at the beginning. So I think that's the main message. Are there any more questions from the colleagues?
Yes, certainly. So one of the next questions is about drift and how much do we tolerate in terms of drift. Maybe I can kind of answer that question myself. So we usually in the trials we've tolerated a drift of somewhere between 0.02 and 0.03 plus or minus. So 1 plus or minus 0.02, 0.03. Otherwise, I think it's important to renormalize, go back down, remeasure, and then, of course, once again, check for drift. But I guess, Javier, maybe this is most important when the lesion is around the cut point. And it's not so important when you have a very significant lesion, and we've certainly seen that. So if it's a very significant lesion, drift doesn't really affect that outcome of whether you stent or not, whereas, of course, where it's right by the cut point, it may.
Absolutely.
And so another question here that we have from one of the colleagues is I think there's still some need for some clarity on the definition of crosstalk and what that might mean. So Javier, maybe you could just explain again what crosstalk might mean.
Yes, when you have a tandem array of stenosis, obviously what you have is that remember that we are using pressure as a surrogate of flow. That's the principle behind FFR. You have a linear relationship between pressure and flow in the coronary arteries because the patient is on hyperemia. Then you know the difference in pressure is proportional to flow. The point is that once that you have a distal stenosis that is very significant, that is the one that acts like a dam in a river, so to speak. And you are not able to see really the effect of the stenosis or the other dam that is upstream. When you relieve, to answer now to the colleague, we are always tempted to infer the relevance of the upstream stenosis by putting the sensor distal to it and checking if the IFR or FFR result is significant. But we know that when you treat the distal stenosis, the value will be immediately altered because the flow through that proximal stenosis will increase dramatically once that you have relieved the more distal flow limiting disease. And immediately your gradient will increase. Now that, as mentioned before, happens much more when you have lots of flow, that means in a hyperemic index, than in a patient that has a resting index, which, by the way, the microcirculation, is adapting the flow to keep it to a minimum and to keep it steady.
Thank you, Javier. For one final question, maybe just before we come to your talk. Matthias, I know you obviously did the IFR Sweetheart study, and there's a question in the audience. Are you happy now just to accept an IFR result? Do you consider it to be your gold standard, or are there occasions where you check FFR?
It's a great question. I think that for us, we do IFR, I guess, in 99% of our cases based on the fact that we're actually using sync vision and pullback for the majority of our cases. And that in itself adds so much more information. I mean, I can think of the odd case where we're not sure that we actually do have resting flow condition that we can complement with an FFR. It's like you're doing non-compilation STEMI, you're going to have a lower IFR because you're not in resting state. Then you can use an FFR in the non-compilation perhaps and integrate the information of the two. But really, we switched to doing IFR in almost all of our cases just based on the fact that we get that more information from the sync vision.
Definitely. So maybe it's now to move to your talk, Matthias, please. So Matthias is going to tell us about DEFINE PCI and the ongoing DEFINE GPS, two studies about IFR pullbacks. So let's see.
So thank you. It's great to be here today to present some of the clinical data from DEFINE PCI and DEFINE GPS. DEFINE GPS is an ongoing trial. Here are my disclosures. So I think if we should have one take-home message from today's session is that probably we should change the way we perform coronary physiology. We should transition from the dichotomous clinical approach that we also used in the clinical trials. We're using a single cutoff point to actually using all the information provided by physiologists, such as we see in the right-hand pane, where we can actually plan the procedure using sync vision. So some important clinical questions to be answered. First of all, pre-PCI physiology can be used to plan the procedure, as Javier elegantly demonstrated. But the other thing, which I personally think is probably even more important, I'm going to show you why, is use post-PCI physiology as a trigger to further optimize PCI. So the really question is, does integration of physiology into the procedure, the way that we perform PCI today, improve clinical outcome? And this is really what DEFINE GPS tries to answer for us. DEFINE PCI was the 500-patient trial where patients with significant IFR equal to below 0.899 were treated according to standard of practice. But after the operator deemed to have a good end result, they did a blinded IFR and a blinded IFR pullback that the operator obviously didn't know about. So looking at this, about 1/4 of the patient actually had residual ischemia. And this is important because there are multiple trials, previously ischemia trials, looking at this and shown that the rate of residual ischemia after PCI hovers around 20 to 30%. So this is really in line with previous clinical trials. But more importantly, here's the answer to this. Out of those patients, 4 out of 5 had focal residual disease. So those patients obviously possibly amenable with PCI. So if we dive into the data a little bit further, of those who actually had residual ischemia, 38% had focal in-stent gradients. In other words, stent under expansion. And this is quite easily fixed by either doing a non-compliant balloon or a larger balloon to fix that, and that will get rid of this gradient. And also 62% had a physiologic miss. In other words, there was an ischemic lesion that was not identified and that's not treated. So this is standard of care today. You fix the tight lesion in the LAD, and you perhaps miss the proximal 50% lesion in the LAD. And this is really what we can see here. Sometimes it's distally, sometimes it's proximally, but all in all, we actually do miss a lot of lesions when we just use angiography to guide our PCI. And it has some significant implications as well. We do know that if you have a low IFR value, same with FFR, it's actually associated with a worse outcome. So I guess from defined PCI, the main question was if all residual lesions, focal lesions, would be treated with additional PCI, we could actually reduce the ischemic burden from 24% down to 5%. That was the diffuse disease. So there's a huge untapped potential for us to do PCI and to sort of improve our results by doing the pullback. So defined GPS is really trying to answer the questions and the findings defined from defined PCI. It's a 3,200 patient global trial. And the main objective is to demonstrate whether PCI guided by IFR code registration, same with what Javier did before, is associated with superior clinical outcome compared to PCI guided by angiography alone or best clinical practice. And it's a combined MACE endpoint at 2 years. So patients are randomized in a 1-to-1 fashion between the GPS arm and the angio-guided arm. The angio-guided arm is best practice, but no pullback or syncvision. The GPS arm, we use both syncvision to plan the PCI procedure and also to check the results using physiology afterwards, and also serving this as a trigger to optimize if needed. And the overall goal is to achieve an IFR value equal to or above 0.95 and try to avoid any focal pressure drops. So this is actually a defined GPS case example. We can see that there is a significant IFR, 0.76. And if we put in long stent in the mid-LAD, we're going to alleviate the disease. 275 by 30 millimeters that was placed. And we see we actually do have a little bit of disease. It's not too bad, actually. I mean, it's only 4 dots, but according to the protocol and defined GPS, we should actually look at this a little bit further. So I did a little bit of IVUS. And we can see that stent looks okay. It's somewhat underexpanded, but it was somewhat underexpanded and along the entire length of it. There's a small edge dissection. I mean, not too bad. We could leave it, but it actually provides a little bit of a pressure drop. So we ended up putting in another stent distally, and then optimization with the 3.0 and non-compliant balloon inside both stents. So in the end results, and I'm sorry, I lost a little bit of code registration, but actually, so we're seeing that there's no significant pressure drop anymore, and we have a good IFR and with good angiographic results. So this is really optimization that is triggered by the post-PCI physiology. And I think almost all of us would say we're pretty happy after the end result of the first one, but we can see that there is actually room for improvement. So if I may summarize, defined PCI really showed that syncvision is more accurate at finding ischemic lesions. We also have the ability using physiology and not IVUS to detect underexpanded stents and also edge dissections. And we have a very large potential to relieve the burden of ischemia from 24% down to 5%, beyond that of angio-guided PCI, which is still best practice today. So defined GPS is really test whether the syncvision guided PCI, as we found in defined PCI, will improve the clinical outcomes. Thank you.
Thank you very much, Matthias. So we can maybe then finish. Time has flown, and we are now at the end of the session. Thank you very much for all the questions. Maybe I can summarize the main key learnings of the session. I think the main idea is that longitudinal vessel analysis with IFR pullbacks and co-registration really can help us define the patterns and define how are we going to treat these vessels. And especially in patients with multivessel disease, like the case that Javier showed, in the end, the multivessel disease transformed in only left main LAD. Also, the possibility of planar procedure and do virtual stenting to predict the result of PCI before embarking in the procedure. And also, as mentioned, physiology post-stenting to try to detect suboptimal functional results and causes that are amenable to treatment, as Matthias was mentioning, stent under expansion or focal residual disease that we have left at the edge of the stents. So with that, I would like to say thank you very much and continue enjoying the course.